Honorable Chairpersons, respected panelists and learned audience, good afternoon. I am Dr. Ahmed from United Hospital, Dhaka. On behalf of Dr. Jahangir Kabir sir, our Chief Cardiac Surgeon, is presenting in this session. Due to some illness, Jahangir Kabir sir is unable to attend this prestigious occasion, and I am going to present. My topics of presentation is end-stage heart failure and role of mechanical assist device. I have nothing to disclose. So as we all know, heart failure is a progressive clinical syndrome with an estimated global prevalence of 26 million. Over the past 2 decades, the pharmacological therapy has a huge progress to treat the patient with heart failure with reduced ejection fraction, but the patients with advanced refractory heart failure, medical therapy often may alone not be inadequate and associated with high mortality in the absence of advanced therapies like ventricular assist device and heart transplantation. Substantial progress in the field of mechanical circulatory support has expanded the treatment options for those patients with end-stage heart failure. The short-term MCS devices are primarily used for high-risk percutaneous cardiac procedure and cardiogenic shock and post-cardiac arrest, while durable mechanical assist device, that is LVAD, are increasingly utilized for the patients with end-stage heart failure. So why VAD is used in end-stage heart failure? As we all know, in end-stage heart failure, the patients become very poor quality of life with a significant reduction in the patients suffer from low output syndrome, the failing heart, unable to pump the adequate amount of blood to maintain the perfusion pressure. This ventricular assist device helps this patient to pump into the body, and which helps them to buy some time. They can be help them to allow to buy some time for transplantation. And even if those patients who are contraindicated for heart transplantation, they can be used as a destination therapy to improve the quality of life and also the quantity of life, that is the prolongation of life, which would have been impossible without the support of the ventricular assist device. And the 2021 ESC guidelines also indicated the use of VADs in this situation. So before choosing a patient to implant a ventricular assist device, and we have to evaluate the patient thoroughly, both medically and psychosocial aspect. Why psychosocial aspect? Because as this device is a very costly device, and patient needs to be very much educated to handle this device. Once implanted into the body to support your heart, this device has to be maintained for a prolonged period. And in order to have a good outcome, psychosocial aspect is very important. Whether the patient has the self-care ability to maintain that device, he can, whether he will be able to maintain the anticoagulation profile and taking care of the driveline, which need to take care for till the device remain within the body. And he has to always maintain a follow-up with his heart failure physician and take some investigation and come to the hospital. And the support of the caregiver is also very important, because once the device is implanted into the body, the surrounding caregiver role has a very significant role, because this device has some function in emergency situation. If the caregiver are not educated enough to handle any complication, it will be disastrous. So psychosocial aspect is also very important. And for medical evaluation, we need to evaluate both cardiac and non-cardiac side. For cardiac evaluation, once the patient with advanced heart failure are referred to an advanced heart failure therapy center, they are evaluated with various things for cardiac evaluation. Like the conventional NYHA and AHA staging of A to D sometimes has some limitation to evaluate what is the worst stage of the heart failure. And that's why Intermax profile, that is the inter-registry for mechanical assisted circulatory support profile, was created to identify those patients who actually need heart failure device in stage 4, stage D or NYHA class 4. And this profile help us to identify the patient who are at the highest risk of mortality and morbidity and to whom we need to implant the device within shortest possible time. As in this graph as shown, where the patient in Intermax profile 1, they are the host group of patient with advanced heart failure with critical cardiogenic shock and the declining their end organ perfusion. And this patient needs to implant within hours. And profile 2 are the progressive declining phase where the patient are on despite inotropic support, the condition is not improving and end organ perfusion is also declining. So these two class of people needs to be implanted with LVAD within hours to days for taking decision. And the profile 3 and 4, those are inotrop dependent, whether we can stop it or win from them. They are having, can be implanted LVAD with elective procedure, and we can buy some time for weeks. And Intermax 5, 6, 7 are the more stable group of people where we can evaluate them and where we can buy some time to whether we will put the LVAD or not. And other than the symptomatic treatment for cardiac evaluation, we have to also look out for the RV function, because once the LVAD is put into the heart, the left side of the heart resulting in appropriate function, sometimes the right side of the heart fail to perform accordingly. And once the right RV dysfunction develop, this patient have a poor outcome in the long run. So in preoperative evaluation, we need to evaluate RV function with echo and cardiac cath. And we also look into the valvular status of the heart, because once the LVAD is put into the heart, there is outflow tract is given into the aorta. And if aortic valve, it has aortic stenosis, it is good, not a problem. But once there is a aortic regurgitation, there is every chance of going from the pump to the aorta and coming back into the LV, which will worsen the and decline the performance of the LVAD. And also we have to check the mitral valve, whether it has stenosis or regurgitation. If there is mitral regurgitation, it will not, it is good because it will improve once the LVAD start to function. But if there is mitral stenosis, there will be inadequate amount of blood will be received in the LVAD, so we have to address that problem during the implantation of the LVAD. And for non-cardiac evaluation, that is the other organ perfusion needs to be evaluated during that period, because lung function, renal function and hepatic function needs to be addressed during the time to see the operability and the outcome of the performance. And also, is there any presence of any infection or coagulopathy is there or not. So once the clinician dealing with the patient with advanced heart failure, this menomic gives us a very clear-cut evidence when we need to refer this patient into the advanced heart failure therapy center, where they will be evaluated to decide regarding implantation of the LVAD, that is, I need help. And optimum timing of the referral is very important, because the attending clinician who are practicing this dealing with this patient, if they are very too late to refer this patient, they are become the Intermax class 1 or 2, and we do not get enough time to support this patient, and the worsening of the outcome is there. And once we put an LVAD, every device has some limitation, and we have to deal with some challenges. Like once the LVAD is put, there is a chance of bleeding, there is infection, there is thromboembolic manifestation, a stroke, pump failure. These are what are the obstacles we need to overcome during the period. But with the evolution of LVAD, and the current third generation of left ventricular assist device, that is HeartMate 3, the currently only available LVAD in the world, has overcome these challenges a lot. Because in this third generation pump, they use fully magnetically levitated technology, which created a frictionless surface within the pump, and there is very minimum chance of thromboembolic manifestation in this group of valve. So once Churchill says, however beautiful the strategy, you should occasionally look for the result. And being the clinician who would like to refer this patient for LVAD implantation, they would like to see the result, whether it is good, this current generation valve or not. Initially, the rematch trial first in 2001 gives us the confidence that the use of assist device had the superior performance over drug therapy in case of advanced heart failure. And the recently published 1 year back, the Momentum 3 trial, which compared the second generation assist device with the third generation assist device in terms of survival and event-free survival, because people these days not only think about survival. When we prolong the life, they want to know whether the prolongation will be event-free or not. And when this study was done, they shows that there is a, as you can see from this slide, from second to third generation slide, at the end of 2 years, there is a gap between the event-free survival. That is 75% of the patients survive at the end of 2 years. And among these patients, this HeartMate 3 valve is associated with need for pump replacement or survival free of disabling stroke, reoperation to replace or remove a malfunctioning valve. And there was an extended trial of the Momentum 3 was done, which evaluate the real-world scenario when there was a long-term outcome of the Momentum 3 pivotal trial, and another continued access protocol study was done of 2,200 patients who were HeartMate 3 was implanted. And they shows in their study that similar rate of survival among the continuous group and the pivotal group, and 2-year survival is almost 80% in HeartMate 3 group. So once this sort of device gives up support and patient benefited from this, we think that we should also give us our patient to benefit from this device. And considering this total benefit, we also offer one of our patients to implant device who was in end-stage heart failure, and I am going to sharing some of our experience with this patient. She was a 42-year-old lady, diabetic, dyslipidemia, arrived in our OPD on a wheelchair. She was on breathlessness on talking and unable to walk, and had a recent history of repeated hospitalization with acute LVF. She was diagnosed case of DCM, related heart failure with optimized GDMT in 2016 in outside the country, and underwent a MRI compatible SICD device was implanted to prevent sudden cardiac death. But no CAG was done during that period. But later on in different countries like Singapore, Malaysia, and Istanbul, Turkey, there was multiple CAG was done, and there was multiple PCI in the LAD, OM, and distal RCA was done. But despite this all support, the patient has an increasing symptom of heart failure, sleepless night, and multiple hospitalization in the recent last 6 months. So upon arrival, we evaluate the patient regarding offering her to implant an NVAD device. The echo shows LVF was 22%, LVIDD 68%, and there was several global hypokinesia with diastolic regurgitation abnormality of grade 3. RVF was 25 to 30% with severe MR due to non-coaptation of mitral valve with normal aortic valve, and PSP of 70 millimeter mercury. And our CAG also done, which reveals patent stent with mild proximal RCA narrowing, and right heart catheterization was also done, and it shows moderate pulmonary hypertension with raised LV filling pressure. PVR was 3.2 Woods unit. And we conclude with the patient of ICM related stage D heart failure, switching between Intermex 4 and 5 on optimized GDMT schedule for left ventricular assist device. So, being the current generation, third generation HeartMate 3, we offered her a LVAD system as a bridge to transplant therapy. And in order to establish this sort of advanced heart failure therapy to the patient with end-stage heart failure, we try to, it was a long process where we attended various seminars, workshops, and built as a team to offer this sort of patient like assist device or heart transplantation. As heart transplantation is not at this moment very difficult to find the donor, we emphasis more on the assist device, and we procure various instruments to combat during the perioperative and postoperative scenario. Like we have procured Sentimec ECMO and nitric oxide to handle during the postoperative RV dysfunction, continuous cardiac output monitor, and lots of things have been arranged at a time to go for the next level. And this is the operative video of our patient, where as you can see, patient is, our anesthesiologists are preparing for and the conventional standard median sternotomy has been, is going on, and aortic and two-stage venous cannulation done. And we are preparing the HeartMate 3 to be implanted. As patient is on pump beating, the apex is elevated to identify the implantation site. There is a marking, and the apical cuff of the HeartMate 3 is, and now we are swinging the apical cuff into the apex of the heart. There, it can be swing first and then coring, or you can also core first and then swing. Now we are applying bioglue, and the apical cuff is now attached and stabbing in the apex of the heart, and coning will be gone. During coning, we have to, their TE guidance has to be there to identify, and the septal wall needs to be addressed whether it doesn't injure the septal wall. So the coding is going on. Coding done, and a portion of the myocardium of the apex is cut. And now we are connecting the HeartMate 3 with the heart. This is the outflow graft of the LVAD were attached, and there is outflow graft. This dearing is going on in the HeartMate 3, and now the HeartMate 3 is attached with the heart. And this is the outflow tract. The pump is going on, and there is a drive line. We are creating a subcutaneous plane to come out the drive line from the HeartMate 3, and it will be connected to the charging port. And the outflow tract is now measured and cut, and a side biting clamp in the aorta is placed, and we anastomosis the outflow tract with the aorta. And after weaning, this is the 6th postoperative day when the patient first walked with carrying her battery with a bag in side poke, and this is the 12th postoperative day when the patient, during his staying in the cabin, she was practicing to going for home, climbing up the stairs, and preparing for discharge and going back to home. And she was discharged uneventfully, and after 1 week of discharge, she was able to attend a program arranged by the United Hospital to meet the press and shared her experience during this journey of heart failure. And this smiling face tells the story. The patient who was having so much symptomatic for the last 6 months, as currently able to, within a month after the surgery, she was able to come into the in a program with a very smiling face and express her experience with us, and she was very happy with the current status of her condition, and with a very limitation previously, but after the implantation of the LVAD, she returned back to her normal activity with very few limitations, get her life back, feel better, and she was able to enjoy her life. So with this experience, we can say that the current generation, third generation left ventricular assist devices are the very durable assist device, are very much feasible for the patient who are able to implant and can have a good, healthy life after the implantation. So I would like to conclude that it is not how much you do, but how much love you put in doing. Thank you all for your patient hearing.